Welcome to week 5 in HEAL 6825, Quality and Safety in Healthcare. This week we're going to talk about preventable adverse events. And boy, I wish we had tons more time to talk about this. There's lots of information. Take a look at your book, take a look at your resources. We are going to just kind of touch on some of the concepts in your slides. Again, it's an area that has a lot of studies. We're talking mostly about solutions this week. So here we go. We talked last week about errors. It's an act of commission or omission, and an adverse event may be an error, but not always. It can be non-preventable, but an error is always an adverse event. So today we're going to look at the types of errors, med errors, and things like that. The first concept I want to mention is failure to rescue. And this is a difficult concept because sometimes it's easier to dismiss because the death is based on known complications. So, for example, if a patient bled to death after surgery, it may be presented as a known complication, and maybe reviewers didn't look back over the case, to see any missed issues. On the other hand, it could be a perfectly appropriate care, but the key is you do have to look at those kinds of outcomes. So basically, it's failure to rescue from a complication of an underlying illness or a complication in medical care. And it's a cascade of events. It's multiple missed signs. So for example, OB is a classic scenario where perhaps deceleration wasn't noted or was noted, but written off as maybe just a one-time issue. Maybe there's a change of shift. Maybe it's not communicated. The baby runs into trouble and they look back over the strips and they can see where there's signs of an issue earlier. It's tricky. Usually it happens over time. A lot of times it's caught when the new shift comes in because the shift looking at the patient is desensitized and thinks, that's how the patient looks. And usually on the morning shift, somebody comes in and says, oh my gosh, has this patient always been like this, and digs in. So again, a very difficult area of analysis. Do watch this video. It's sad. Helen Haskell, I've met. She's a very nice lady, with a very, very kind lady with a very sad story about her son, but you can see how the events happened over time. Even though there are questions that are kind of dismissed or explained away, take a look. It doesn't take a long time to take a peek at. I wish we could go into a little more depth on this, but again, do take a look at this video. Surgical errors, we're going to switch gears again. You could spend, a whole class on this too. We know that surgical errors, in general, the more procedures done, the safer the procedure is in general, and that's what Leapfrog, that's an employers group, bases some of their measures on. So, if you're looking for quality measures, if a site does a lot of transplants, for example, as opposed to a place that does one or two, it may be a safer place. In general, there's always exceptions, and many places in low volumes do fine procedures as well, but fewer complications with a higher volume of case. Wrong site surgeries continue to be an issue, although we see fewer of the really catastrophic events. I know in my law school book there's a picture of a jar left in somebody's abdomen. We don't see as much of that anymore. A lot of times it has to do with the level of, for example, a spinal pain block. Still serious, still have to look at it, but we don't see as many, oh my gosh, horrible things as before. The wrong patient, of course, is always concerning, and you still see issues of that nature pop up. Retained foreign objects still are an issue. Again, maybe not to the degree that you would see before, but you still have them. There's still sponges left in somebody. Sometimes they're little pieces of equipment. Maybe a lot of times you see it during emergency surgeries where sponges, when they're wadded up and soaked with blood, are difficult to differentiate with from tissue. So you do still see them, but maybe to a different degree. And now you see them in things like outpatient wound care, where they still can cause an issue. Surgical fires are an issue that does happen even today, and there's measures in place. Everybody should have a plan. And then procedural events outside the OR as well, because procedures are done outside the OR, but maybe don't have the same counting procedures and other preventative measures. We talked about this slide last week, where anesthesia and blood transfusions really have put measures into place that make error less likely. The WHO checklist was developed about 10 years ago, and it was shown in the first studies to decrease mortality by 50%. And these are all things, when you look at, that can go wrong in surgery. So is the pulse oximeter on? You can deduce from that there's been a number of cases where maybe it wasn't on or available. So, just making sure the site's marked. Do we have the right patient? Is there a difficult airway? Is it a ASA patient 3? Do we need backup equipment? Do we need blood? All the way down the line, do we need imaging? And then even before the patient leaves the OR, of course, the sponge count, but specimen labeling as well. Sometimes you have a brain surgery or a biopsy of a tumor and it's removed, and you can't really nip in there and take another sample if it's lost. So those kinds of things seem very simple on its face. And it's interesting around implementation. So the first study showed a 50% reduction. Many institutions pushed for this quality control. It's pretty much in every OR because the thought was 50% is pretty significant. We've relied on a lot less evidence to put measures into place. A second study in the Netherlands seemed to confirm this. But later, a Canadian study and a Medicare patient study showed no improvements. And what this is in your readings, there's implementation issues, and success is linked to culture, among other things. Diagnostic error is another area, and this is firmly linked to human factors analysis and patient safety science. It's how people think. So it's a failure to establish an accurate and timely explanation of a patient's health problems or communicate that explanation to the patient. Sometimes it can be an administrative type function. A lot of times it has to do with how practitioners think. Generally, these errors live in peer review system, physician and advanced nurse practitioner peer review systems, which is separate from the incident reporting system and based on individual performance. But this is an area where we know that there are issues. It's underreported, it's difficult to count, and it's difficult to address. Again, it's based on some cognitive errors. One thing is maybe you hear the initial portion of the case and one begins to think of the scenarios to explain the facts, not modifying opinions as more facts are available. That should be. And then heuristics are cognitive shortcuts. And I always think of Admiral Akbar because, and from, I think it's Empire Strikes Back, where he says it's a trap because your mind actually leads you down these little cubby holes, and it tricks you just because you try to take shortcuts to get through things quickly. Here's some different types of biases, and I won't go through each one. One that's interesting is availability bias, where if you've just read an article about a new diagnosis of a condition, and maybe a physician goes in, and the next patient he or she sees, they're like, oh my gosh, they have this thing I just read about. And that's a trick in the mind. Sometimes anchoring, affective bias. Sometimes you feel something about a patient, maybe patients like your grandma or something, or context errors. So all of those things are very interesting to read about. There's a nice section on it in Wachter. Med errors, and again, we could talk for ages on this. It's a preventable event as opposed to an adverse drug reaction, which is non-preventable. That's when you give a medication and somebody has a complication and you report that to pharmacy, and they transfer that information to the FDA. But again, that's both are underreported. But again, adverse drug reaction is non-preventable. And a medication event is preventable. So there's 4 stages: ordering, transcribing, dispensing, administration. And this week we're going to be looking at a particular case that happened in Wisconsin. You saw the picture of that nurse getting sentenced. So the first story, we talked about first story and second story last time, is the laboring mother receives the incorrect epidural dose and dies. That's the first story. That's something that might be written in an incident report. Okay, well, let's blame the nurse and go on. So that's not the case. When the root cause analysis was looked at, they found that there's pressure to prepare the epidural bags in advance because the barcoding system didn't work. There were overlooked labels. Again, if you look at cognitive, how your mind works, stickers can easily be ignored. If you've gone into a store to buy Diet Coke and you come back with Diet Coke with lime, and you're like, how could I, the labeling is similar, even though there might be a green thing on the lime. It's just how your mind works. It picks out the things that you think are there. There's wristband and scanner issues, and there is also fatigue of the caregivers. And for your paper, it's interesting because the Smetzer article that you'll look at doesn't talk about fatigue of the caregivers. And so Decker and Denham have a little something to say about that, and take a look and see what you see. But in that particular case, that's definitely something to look at, and they didn't. Here are the labels, and it's in the article. They picked the wrong, the nurse picked the wrong bag, and here she is. So sad. The ambulatory environment, and we don't have a lot of time to go over this, is a different sort of environment, slower pace, very high volume, different, the high volume of cases, they might be less severe, but probably many more as an impact. And some aren't as regulated as hospitals. So you may have clinics that aren't regulated by the Joint Commission. There's often not the same set of measures you would find in the hospital setting. I won't go through all of this. It's really a fascinating area if you are planning to be working in a clinic or community setting. Really do take a look at the Wachter material, because we realize not only the errors occur in it, but that continuum of care, communication, we'll talk about teamwork, is also a challenge. And here's some common sources. So I can't go through all of these slides now. Here's some good news around the ambulatory settings. I want to say one more word, and I think I have 15 seconds. Take a look at root cause analysis in your book and the Smetzer article. You guys have a good week, and take care.